Hello everybody. I'm Prash Jesudason, consultant hand and orthopaedic surgeon at Ysbyty Gwynedd, and thanks for the opportunity to talk to you about the assessment of patients with carpal tunnel syndrome. Carpal tunnel syndrome is really common, so this is something that you will all see in your day-to-day practice, and I'll share with you my experience on how to assess these patients. So as with everything in medicine, if we open our ears and listen to what the patient tells us, they will give us the diagnosis. And patients with carpal tunnel syndrome describe a number of features, and everything is in the history. So the history will give you the answer almost all the time, and the examination and the special tests are there to substantiate your history. So patients will often describe paresthesia, and this is usually nocturnal, so that is the key one question, is if the patient describes pins and needles in their hand that wakes them from sleep, it's highly likely they have carpal tunnel syndrome. Now the paresthesia is usually intermittent. It can be constant, which indicates a relatively poor prognostic sign, as it means that the compression is quite severe. And it isn't always nocturnal. Some patients with carpal tunnel syndrome describe pins and needles on grasping activities, things like driving, holding a phone, preparing food, using a knife and fork, peeling potatoes is a classic one. So these questions are all quite useful. So going back to the history, I would ask the patients, you have pins and needles, describe the pins and needles, where in the hand are they feeling it? So when looking at the median nerve distribution in the hand, carpal tunnel syndrome generally affects the radial half of the hand from bisecting the ring finger. So everything this side of the mid portion of the ring finger is supplied by the median nerve, and everything that side is supplied by the ulnar nerve. Now, patients will sometimes describe to you that the pins and needles predominantly affects the thumb, index and middle fingers, but not always. Many patients will just describe the whole hand as numb, pins and needles, cold, or buzzing. A lot of patients describe this word buzzing. So that's the paresthesia. So what brings it on? Now, classically with nocturnal paresthesia, it's not just does it happen at night, but does it wake you from sleep? Now that's quite important. Some patients wake up with numb hands. Some patients have intermittent numbness first thing in the morning. But what the key objective is, does it wake you from sleep? And then what do you do? A lot of patients will describe getting up, walking around, shaking out their hands, and taking a long time to settle and go back to sleep. And that's quite clear in the history, and that's highly suggestive of carpal tunnel syndrome. And like I said before, we're looking at aspects of what tasks bring on the pins and needles. So anything that involves overhead activity. So as we raise our hands up, this also can cause tension on the median nerve and can provocate the symptoms. So I've seen patients describe pegging out washing, causing carpal tunnel syndrome, or putting objects in high cupboards, or even just reading a newspaper or holding a book can cause carpal tunnel syndrome. So that's paresthesia. So nail paresthesia in your history, find out what the provocating symptoms are, where they're feeling it, what brings it on, what relieves it. The other questions I would ask are one of pain. Carpal tunnel syndrome can be quite uncomfortable and quite painful. And patients can describe pain in the hand, in the fingers, and often they describe aching in the distal forearm. So I would always ask about this pain as well. And pain can also be a bit of a red flag sign, which I'll come back to in a moment, that patients with a lot of pain could have severe median nerve compression. The other thing to ask about, which we're not very good at asking about, is loss of coordination. A lot of patients will describe difficulties with fine dexterous tasks. So holding a pen, writing, doing up buttons, tying shoelaces. These tasks can be quite cumbersome. We understand that carpal tunnel syndrome does affect the way we grasp objects, in terms of both the loss of sensitivity to the digits, but also loss of motor function and loss of proprioception. So the brain doesn't really know exactly what the digits are doing in space, as well as someone without carpal tunnel syndrome. So ask about fine dexterous tasks, and your patients will often say, I struggle with buttons, I struggle with shoelaces. I put my hand in my pocket and I'm not sure whether I've got a 20 pence piece or a 5 pence piece. These kind of issues. So that's the history. The other thing we want to ascertain is what issues there could be in a differential diagnosis. So ask the patients if they have any history of peripheral neuropathy. Are they diabetic? Are they taking any medications? Are they hypothyroid? That's quite important, because we know that hypothyroidism is a cause of carpal tunnel syndrome. Ask about pregnancy as well, and also ask if they have any history of neck disorders. So if they've had a neck injury in the past or a cervical disc prolapse. And ask if they have any elbow or shoulder pain. So ask about the whole upper limb, thinking about the sites of compression they could have. And also ask, in terms of going back to the peripheral neuropathy, ask them about any loss of sensation, pins and needles, discomfort in the lower limbs. So what we're specifically looking at in the differential diagnosis is, the first thing I would say is this a C-spine problem? So think about other sites of mechanical compression. And I would say the first site would be a cervical disc. So ascertain if the patient has any neck pain, and also if they ever describe any electrical type symptoms spreading down the hand, particularly in certain movements, if they have a sudden discomfort. Also ask them about elbow discomfort. The median nerve can not only be compressed at the carpal tunnel, it can also be compressed in the elbow. In the proximal forearm and distal humerus region, there are sites of compression of the median nerve, and these are quite difficult to diagnose, and patients may simply describe a little discomfort here, which is often confused with things such as tennis elbow. And then also ask about shoulder discomfort. Another difficult diagnosis to make is one of thoracic outlet obstruction, which is another site of nerve compression in the upper limb. So as the nerve roots leave the C-spine, they pass through a small space behind the clavicle, and as the nerves leave the neck and thorax into the arm, there is a site of compression there. And these patients often describe shoulder discomfort and discomfort in this area on certain movements. And this needs further assessment if this is considered. So going on to examination. So the first thing to do an examination is obviously to inspect. So there's a few things to inspect. First of all, look at the overall resting posture of the hand. Look for any obvious muscle wastage. So this is the thenar eminence. Now this group of muscles is predominantly supplied by the median nerve, and the way I tend to assess it is move the thumb away from the palm, what we call abduction, and this tightens up this muscle, and it should be sort of a firm chunk of meat. And if it's soft, if it's a bit floppy, obviously compared to the side, or if there's complete loss of definition of that muscle, that would be wasting. And then look over the hypothenar eminence. Now the hypothenar eminence is supplied by the ulnar nerve. Now often patients can present with combined median nerve and ulnar nerve problems, so it's quite important to assess the ulnar nerve as well. And also look at the overall resting posture of the hands. If there is a claw posture to the digits, this may indicate a severe ulnar nerve problem, or if there's a hyperextension deformity like this of the MCP joints, this may also indicate a severe ulnar nerve or combined ulnar and median nerve palsy. Looking on the back of the hand, we also look for wasting of the interossei. These are small muscles that sit within the bones of the hand, and wasting of these will also indicate an ulnar nerve problem. And the other thing I forgot to mention is have a look for any swellings in the hand. Occasionally we see things like lipometer, so soft swellings or ganglions, which could be responsible for any local compression. And also have a look for evidence of scars. Now, scars on the hand can heal extremely well. Now, I've actually had a carpal tunnel decompression about 5 years ago, and unless you look really carefully, it's almost impossible to see. So have a look carefully for scars, surgical scars and also traumatic scars, and ask the patients if they have had a nerve injury as well, if you do see a scar. The next thing I would do is to assess sensation in the hand. And what we go for is a part of the median nerve that is only ever supplied by the median nerve, what we call the autonomous zone of sensation. And that is the tip of the index finger. So basically, I ask the patient to close their eyes, and can they feel the tip of the index finger? And compare that to another area, either the other hand or another aspect of the arm that is not involved. So you're comparing it with something that is already sensate, and say, can you feel that? And don't just say, can you feel it? Ask them, does it feel normal? Because patients can feel it, but they may say, oh, it feels odd, it feels buzzy, it feels fuzzy, it feels more sensitive. Some people describe hypersensitivity in carpal tunnel syndrome, and some people describe the other end of the spectrum, complete numbness, and they just can't feel it at all. So do that on the tip of the index finger, which is the median nerve, and then compare it to the tip of the little finger, which is the ulnar nerve, and document the difference. Another test which is quite useful is localization of touch, which I occasionally do if I'm in doubt. So what I do is split the finger into quadrants and name them A, B, C and D, and on a diagram of the hand ask them to, and then if you ask them to close their eyes or look away, and if you touch one quadrant, ask them to name which quadrant you're in. And localization of touch, or locognosia, is another tool we can use to assess patients with a sensory problem. So that's motor assessment, altered sensation and sensory assessment. And then we look at the special tests. And there are two special tests we use in carpal tunnel. Well, two main ones that you need to be aware of. And the first one is Phelan's test. And Phelan's test is very simple. Have the patient on the desk and just flex the hands forwards. Now, in a busy clinic, in a busy atmosphere, you have 20-30 people in the waiting room, I will often put them in a Phelan's position whilst taking the history. Okay, because you really need to have them in this. Phelan described this test over 60 seconds. So keep them in this position. Now, if you keep anyone in this position for long enough, they will have carpal tunnel syndrome. But I think at least 30 seconds, ideally 60 seconds, keep them in this position. And if it provocates the symptoms, it's suggestive of carpal tunnel syndrome. So that's a Phelan's test. Some people do a modified Phelan's test, which I must confess I do, which is gentle pressure on the median nerve and then hold them in flexion. So you can do that with the patient in this position as I am, or we can do that from the other end of the table in this position, holding them like this. So that's a Phelan's test. The other test is a Tinel sign. Now, Tinel sign is basically gentle tapping on an irritated nerve. It was initially described in nerve injury, where a nerve is cut or severed or stretched, but it can also be used in nerve compression to identify the site, basically where the nerve isn't happy, where it's being compressed. And it's very simple. The median nerve runs just to the side of the FCR tendon, right in the centre of the distal forearm. So I start distally and gently tap along the median nerve. Now be careful not to tap too hard, because if you tap any nerve hard enough, it's going to be uncomfortable. So just gentle tapping. And the patient may say, oh, that's very uncomfortable there, or oh, that's very uncomfortable there. And that's the site where the nerve is particularly under tension. So I do this over the median nerve, and I also do this over the ulnar nerve at the elbow. I'll come back to the ulnar nerve in a moment. So those are the two special tests on the hand. Now, if you recall, previously I spoke about the median nerve being compressed at the elbow. Now the median nerve runs up the forearm and passes under a structure called the bicipital aponeurosis, where it can be tethered and compressed. So feel the biceps tendon, and just this sheet of tissue, just ulnar and distal to the biceps tendon, I gently have a feel there, do a little Tunnel's test there, and the median nerve passes just posterior to the biceps tendon and the biceps muscle. So I gently tap along here and also have a feel of the area, right up to the mid-humeral region. If this is extremely tender, there is a chance that the patient may have median nerve compression at the elbow. Many patients will have a combined median and ulnar nerve problem, so always examine the ulnar nerve very carefully. So we've described a Tunnel's test at the elbow, and the other test I undertake is a couple of things. First of all, assess what we call the carrying angle of the elbow. Is the elbow nice and straight, or is it off to a marked angle? So patients with an arthritic process or post-trauma may have a flexion contracture of the elbow, or an elbow which is slightly angulated in what we call a valgus position, where it moves towards the radius. And these are risk factors for an ulnar nerve problem at the elbow. And what I tend to do is a simple test called the elbow flexion test, where basically we just keep the elbows flexed in this position, again for about 60 seconds, just to see if it's provocating pins and needles in the little finger. And if it is, it's likely that there is compression of the ulnar nerve at the elbow, which is known as Carpal Tunnel Syndrome. And then I also simply check neck movements. If the patient has good neck movements and there are no particular aspects of neck movements that provocate the symptoms, I don't tend to do any further major neurological assessment. If I'm concerned, I'll do a full upper limb neurological assessment of myotomes and dermatomes. And as a very broad test for thoracic outlet syndrome, to see if there's any compression of the nerves as they leave the neck and enter the arm, I do a simple nerve root tension test. So put the arm fully straight, stretch the hand out like this, and I ask the patient to turn away, and that puts the whole brachial plexus under a bit of tension. And if you just push back slightly, and if the patients describe extreme discomfort there, this may be a problem at the thoracic outlet. And that would conclude my assessment of the upper limb neurology in a patient with suspected carpal tunnel syndrome. The final thing to say is also assess the lower limb nerves if you're concerned, if there might be peripheral neuropathy. So ask to see the patient's feet, ask about diabetes. The other thing to also ask is alcohol consumption. So alcoholics can have an alcoholic peripheral neuropathy, which is important to ask about as well. And then the final thing, the second final thing, is to go over what I call red flag signs. So when I'm really concerned, when a patient needs to be referred on an urgent pathway. And we've already alluded to this. First of all, muscle wastage. So if you look at the hand here and there's complete scalloping of this muscle and there's just nothing there, that is severe compression. If there is severe pins and needles, which is constant, which is not going away, this is a potential red flag sign. And if there is severe pain, so a lot of patients describe severe pain, have marked carpal tunnel compression. And the other red flag thing to mention is that patients with visual impairment who rely on touch, for example using Braille, these patients really must be referred on an urgent pathway, even if you are just suspecting that this might be carpal tunnel syndrome, as the stakes are so high for them and we just cannot afford for them to lose any sensation in the hands. So thank you for your attention, and I hope you found this video useful.